Definitely there is a very big question about it. For knee, it's a big area. Now everybody is into the knee, but for the hip, there has been a bias against, as I said. Though we understand it is 1992 when the first surgical robot for THR started with it. And as compared to knee joint, things have not been able to take care. While if you look at, we predict that robotic systems such as ours will provide surgeon with unprecedented degree of precision for the procedure like THR that was stated that long time back. We have appreciated that robotic hip surgery gives impressive accuracy, minimally invasive, expect a better patient satisfaction, natural feeling, joints are all okay. Some downsides are reported like no tactile feedback, maybe injury to the surrounding tissue does exist. But if you look at the systems, every system, whether it is active, has got its own issues, semi-active has their own issues. We need enough studies for the hip also. The first robot which came, so-called robot Doc Walls, it proved that it can give a better stem alignment, less problem with the limb line discrepancy, less pulmonary embolism events, and had a less stress shielding when it was evaluated with the robot. And thereafter, we have got a reasonable number of publications, whether they were linked with the component alignment in the stem or the acetabulum, or component fit and fill in the stem, or the clinical outcomes. Enough number of papers got published into this area. And what has been said in all of them, there is a doubt, and I am talking about knee now. Some people feel that some experienced surgeons can meet or exceed robotic accuracy even in the knee joint also. But what about the hip joint? We have still to evaluate. As regarding cost effectiveness, yes, just like knee also, more the number of hips you are eventually doing, the cost is likely to reduce. Just like from 100 joints, it is 12%, rise to 300 joint, it comes to 6%, because obviously the needs are met accordingly. And this happens in other studies also. Now, what is the scenario in 2021 regarding hip? 224 clinical studies have been published on the robotic orthopedic surgery. Mostly we understand they are from US, and look, second number is China. We are India, still far away. Most contributions are coming from one hospital, that is from China, all the robots. And the most scholars in the world right now talking about robots are either Tien Wei from China or Mount Michael from, most productive authors. And top 30 articles, 29 publications are cited at least 40 times. And the journal which has published is Journal of Arthroplasty, that is robots. But question given to me was, what about the complex hip? Standard hip, things have come up very well. This is the cup, these are the anatomical parameters which you have to say. What about the complex, when those anatomical parameters do not exist as comfortably as they happen in the knee joint? So there have been papers in dysplasia hip also that these kind of a patients can be taken for a hip replacement. And this paper says with a series of 79 patients, yes, it is an adequate and a useful method which can give us a good component positioning and an excellent outcome. Another paper also says that it, and this is from the American Academy of Orthopedic Surgeons, it can minimize the failure rates and the revision rates also. Yeah, we agree that it is a steep learning curve, the cost is higher, but it is still good. This paper in 2020 states that even arthrodesis is not a situation where it cannot be done. Yes, it definitely, it offers good haptic constraint control over the depth of reaming. So that is also very much possible. Another paper also says the same thing, that it provides a real-time information and it can work well for the fused hip also. What about the obesity? Definitely. Now, as compared to knee, which is a very superficial and you flex with whatever the obese patient is, knee is very superficial. Here, the hip is a deep area. Again, a big complexity, but still, they have been able to find it out that here also, Robo can do the job. It can provide accurate and reproducible state placement of the cup. So it does well in that situation. And another paper also supported the same thing, that though it is challenging and can be associated with complications, but it definitely helps in precise cup position as well as the soft tissue balance, and they are definitely the major advantages in the hip also. Then there are case reports. Again, I am saying there are case reports of those complicated situations which are getting published right now. So we have lagged behind the TKR in THR robotic. We are still working on those complex situations with the case reports getting published in 2021, 2022, and maybe this year also. Another case of a complex hip is a kind of a trauma post-acetabulum fixation where the cup placement. But take care, here the anatomical parameters are defined. We can get our indicators. But if these are not there, though the paper says this, another paper says there is a bone loss dysplasia post-traumatic, it can work. If these are altered, just like in a keratostomy also, it can still be working up and it can still provide that help in placement of the cup. Revision scenario, another situation which is likely to complete. Again, there are 7 reports and look at it. It was in 1998 when they did try the robotic in the revision also. Now the problem is the previous cement, so they had to take it out and they wanted to confirm by arthroscopy whether it has been taken out or not. So combining the systems, now where we are 20 years or 20, 30 years later is little more. Then there has been MECO only system where it has been found it out. Yes, it can work, and that is 2021. The problem comes, what exactly is the difference between knee and hip? Why in hip we are worried about? Because the anatomy is different. If the anatomy is standard, we know these are anatomic parameters, you can put it over. But what about these cases? They need much more than the anatomical parameters. No parameters defined. There only the surgeon can do the job. So we understand that surgery is getting into a standard hip arthroplasty. We still had more work to be done to support complex arthroplasty. Till that time, it is surgeon only. We understand our future success is directly proportional to our ability to understand, adopt, and integrate new technology into work, but we need to, and this is the desire. Thank you.